going through different types of urinary system disorders, we're going to start with inflammatory disorders. So any part of the urinary system can be affected by inflammation, and inflammation caused by infection a lot of times. So urinary tract infections are very common. Urine is an excellent growth medium. It's warm, it has nutrients, bacteria like it. So lower urinary tract infections, cystitis, which is a bladder infection, and urethritis, infection of the urethra. Upper urinary tract infections include pyelonephritis. E. coli can be a causative organism because they all kind of live in the same area, or they can get into the urinary system. Urinary tract infections are more common in women because the urethra is shorter and it's closer to the anus, so the E. coli are in closer proximity. In older men, they are more prone to prostatic hypertrophy and urine retention, and so they can have problems with urinary tract infections. Some congenital abnormalities in children make them more prone to UTIs. Other predisposing factors could be incontinence, retention of urine, or direct contamination with fecal material. So lots of different causes for urinary tract infections. In the elderly, because they have their immune system is more compromised potentially, urinary tract infections can have widespread effects, and they can actually progress to septicemia. With older people, you tend to get more cognitive effects with urinary tract infections. So sometimes, if you're working in a skilled nursing facility, primarily with older people, maybe you're working with someone one day, the next day you go and see them, and they seem to have declined physically and or cognitively. That is a good time to contact the nursing staff and tell them something's wrong. They might need to get a urinalysis or a culture and sensitivity on the person's urine. They might have a urinary tract infection. It can affect them. It can decrease their endurance. It can decrease just their functional mobility and their cognition. So urinary tract infections can be easily treated. They can also be quickly progressing to something that's causing someone serious problems. So cystitis and urethritis, the bladder wall in cystitis and the urethra in urethritis are inflamed. And it can cause hyperactive bladder and reduced bladder capacity, so frequent urination is a symptom of that. Pain is common in the pelvic area, so dysuria, urgency, frequency, and nocturia. So difficulty urinating at night, urgency and frequency. Systemic signs might be present, like fever, malaise, nausea, or leukocytosis. The urine's often cloudy with unusual odor. And the urinalysis usually indicates bacteria in the urine, sometimes pus, and sometimes blood in the urine. With pyelonephritis, one or both kidneys are involved. So it can be infection that moves from the ureter into the kidney. Sometimes you get purulent exudate that fills the pelvis and the calyces. Recurrent or chronic infection can lead to scar tissue formation and loss of tubule function. It can cause obstruction and collection of filtrate, hydronephrosis, where the filtrate builds up in the kidney, and eventual chronic renal failure if left untreated. So pyelonephritis is a serious diagnosis. The signs of cystitis plus pain associated with renal disease: dull aching pain in the lower back or flank area. Remember in the last section when we talked about where the kidneys are, they're high up underneath the ribs in the retroperitoneal space. So that dull aching pain in that flank area can be associated with renal disease. Systemic signs can include high temperature. So the urinalysis is going to be similar to cystitis, where there might be bacteria or pus or blood in the urine. You also might see urinary casts, those skeletons of the red blood cells. And that is a reflection of renal tube involvement. it's treated with antibacterials. And of course, they're going to do a culture and sensitivity to find out what organisms are involved and what they're sensitive to. Glomerulonephritis can take many forms. A lot of times, it has to do with a post-streptococcal infection. So you get these anti-streptococcal antibodies, the formation of antigen-antibody complexes that activate the complement system, and it produces an inflammatory response in the glomerulus, the glomeruli. Increased capillary permeability because of the inflammatory response, and leakage of some proteins and large number of erythrocytes into the urine. It can cause a severe inflammatory response. Congestion and cell proliferation, and decreased glomerular filtration rate, which causes retention of fluid and waste, and then it upsets our fluid balance and our acid-base balance and our electrolyte balance. So with glomerulonephritis, the urine becomes dark and cloudy. You might get facial and periorbital edema initially, so around your eyes. General edema usually follows. You can get elevated blood pressure because of increased renin secretion and decreased glomerular filtration rate. So the blood pressure system is affected. Flank or back pain, because those kidneys are high up there, and the flank or back pain is usually caused by edema and stretching of the renal capsule. You get general signs of inflammation and decreased urine output, which is oliguria. The blood tests that they take, you'll see elevated BUN and creatinine levels, elevation of anti-DNase B and streptococcal antibodies, anti-streptolysin and anti-streptokinase. Those are enzymes that react to those streptococcal antibodies. Complement levels are decreased, and they're used in renal inflammation. You can see metabolic acidosis, you can see protein, blood, and erythrocyte casts in the urine, but no evidence of infection. So it's a little bit different presentation from some of the other inflammatory processes. The treatment is they restrict sodium, they restrict protein and fluid intake, and they're treated with glucocorticoids to reduce inflammation and antihypertensives to address the blood pressure issue. So it's different from an infection. It's an inflammatory process, but they're treated differently because it's not caused by a pathogen. So this is the flow chart from the book for the post-streptococcal glomerulonephritis. And it's mostly those antibody-antigen complexes that basically block up the glomerulus, and they reduce glomerular filtration rates. So you can see down at the results section, the majority have a full recovery, so yay on that. A few have acute renal failure leading to death. That's not good. Some end up with chronic glomerulonephritis leading to chronic renal failure. So mostly full recovery, but there's some other potential side effects that can lead to death or chronic renal failure, which chronic renal failure can also lead to death. Nephrotic syndrome, it's an abnormality in glomerular capillaries. Increased capillary permeability and large amount of plasma proteins escaping into the filtrate. They don't know what causes it in children 2 to 6 years old. In older people, it might be secondary to lupus or exposure to nephrotoxins or drugs. So the hypoalbuminemia, which is lowered albumin in the blood because those blood proteins are moving out of the blood and into the filtrate because of the decreased plasma osmotic pressure. So you get generalized edema. Blood pressure stays low or normal. even though it may be elevated if you have elevated angiotensin II levels. Increased aldosterone secretion in response to reduced blood volume can cause more severe edema. So high blood cholesterol is a sign, lipoprotein in the urine, lipiduria, which is lipids in the urine, and it gives the urine a milky appearance. So one of the first jobs I ever had, I worked in a hospital chemistry lab, and so it is really interesting to kind of see the different appearance of some of these specimens. And some of them, you can look at them and you can say, there's obviously something wrong here. And the people with a lot of experience can a lot of times tell what's wrong just from looking at it. And then they can test it to verify their observations. So with nephrotic syndrome, you're going to see protein in the urine, lipids in the urine, and those red blood cell casts, massive edema, and a sudden increase in girth. So that's from the edema. It's treated with glucocorticoids to reduce inflammation, with ACE inhibitors to decrease protein loss in the urine, because ACE inhibitors are going to restrict that capillary permeability. It's treated with antihypertensives, and sodium intake might be restricted. So, moving on to urinary tract obstructions. A lot of times, urolithiasis or calculated kidney stones. They can develop anywhere in the urinary tract. They can be very small or very large. They tend to form with excessive amount of dissolved solids or solutes in the filtrate, or insufficient fluid intake. That's a major factor for the formation of kidney stones or a urinary tract infection. So, if the stone is large enough to obstruct the urine flow, it can lead to infection. It can lead to hydronephrosis, which is fluid in the kidney, with dilation of the calyces. If the stones are located in the kidney or the ureter, you can actually get atrophy of renal tissue because they can block circulation. So this is a picture of a kidney with different stones, and so the graphic shows where the stones are. There's a huge one in that dilated area at the bottom, and then there are a lot of smaller ones throughout. So obviously this kidney was severely compromised with the stones, and the fluid building up, that's the hydronephrosis. So a lot of times kidney stones are composed of calcium salts, high urine calcium levels, and they form readily because urine is highly alkaline. So the calcium salts precipitate out and form those stones. You can also get uric acid stones if you have high uric acid in the blood. It's also known as gout. High purine diets or cancer chemotherapy or genetic predisposition can form those uric acid stones. There are other types of stones, and the stone formation and the type of stone that's formed depends on the predisposing factor. So it could be that you have gout, it could be that you have high urine calcium levels, it could be other chemical levels are high in your body. So a lot of times they're asymptomatic if they're in the kidney or bladder because they're not moving around. You're not going to notice them unless they're obstructing something or causing other problems. So sometimes people have frequent urinary tract infections, and then that leads to investigation that shows that stones are there. Flank pain is possible, but not always with kidney stones. Renal colic is spasms of pain in the flank area, and it's caused by obstruction of the ureter. A lot of times those pain spasms radiate into the groin area, and they last until either the stone passes or it's removed. It can cause nausea and vomiting, rapid pulse, and cool, moist skin. So a lot of times they have radiological examination to confirm the location of the stones. Usually small stones, they will just let you pass them. They have the shock wave lithotripsy, the extracorporeal, so it's outside the body. They use a shockwave to break up the stones. They have laser lithotripsy. Drugs may be used to dissolve some types of stones partially, and surgery to remove the larger ones. To prevent stones, they want to treat the underlying condition. So if you have gout or high uric acid in your blood, they have medications that treat that. Dietary modifications and increased fluid intake to prevent stones. Hydronephrosis is a secondary problem that can be a complication of calculi or stones. It can be caused by tumors or scar tissue in the kidney or ureter. It can be caused by untreated prostatic enlargement or developmental abnormalities that restrict urine flow. So it's frequently asymptomatic in the early stages because, like we talked about in the last section, the kidneys have highly redundant features, and so part of it could not be working, but the rest of it is doing fine. Hydronephrosis can be diagnosed with ultrasounds, radionuclide imaging, CT scans, or renal scans. If the cause of the hydronephrosis is not removed, it can cause chronic renal failure. So tumors, of course, just like every system, you can have cancer. So renal cell carcinoma is a primary tumor arising from the tubule epithelium. It's more often in the renal cortex than in any other part of the kidney. They tend to be symptomatic in early stages, so unlike the digestive system cancers that are asymptomatic in early stages, they can, if they're symptomatic, it's more likely that they're going to get treated, which is nice. But if there aren't enough symptoms that someone's going to seek treatment, then they often metastasize to the liver, lung, bone, or central nervous system, and that can't be good. They occur more frequently in men and smokers, and the treatment is removal of the kidney. Sometimes they use immunotherapy to target the tumor. If the tumor is radioresistant, and chemotherapy is not used in most cases. So, removal of a kidney, that's pretty serious. Luckily we have a spare. As long as the other one's not affected, you're okay. But you might end up on dialysis if the other one's affected as well. So painless blood in the urine initially, either gross or microscopic. So you might not see it. It might be microscopic. Dull aching flank pain, a palpable mass sometimes, unexplained weight loss, that's a red flag for potential for cancer, anemia or erythrocytosis, and paraneoplastic syndromes like hypercalcemia or Cushing's syndrome. So remember, those tumor cells can send out hormones in excessive amounts, and they can cause these other problems. Bladder cancer, because bladder cells, those bladder epithelial cells are transitional cells, they change a lot. A lot of bladder tumors are malignant, so they arise from that transitional epithelium of the bladder, and they often develop as multiple tumors. They're usually diagnosed by urine cytology and biopsy. So the early signs are difficulty urinating, dysuria, or blood in the urine, hematuria, and infection is common with them. The tumors, because the bladder is thin, a lot of times they're invasive through the wall to adjacent structures. And they can metastasize to pelvic lymph nodes, liver, and bone. So it can be a pretty serious cancer. So working with chemicals in laboratories and industry, particularly aniline dyes, rubber, and aluminum, can predispose you to bladder cancer. Cigarette smoking, recurrent bladder infections, or heavy intake of analgesics. Treatment is usually surgical. It can also be treated with chemotherapy and radiation in combination with surgery. And sometimes photoradiation is successful if it's applied early enough. So, nephrosclerosis, if you think hardening of the kidney, it's a vascular disorder. It involves vascular changes in the kidney, which some occur normally with aging. You get hardening of, the arteries, you get hardening of other organs as well. So it's a thickening and hardening of the walls of the arterioles and the small arteries, and narrowing of the blood vessel lumen. So it reduces the blood supply to the kidney. It stimulates renin, which increases blood pressure. So the kidney is often involved in blood pressure issues. So if you have continued ischemia, it can result in destruction of renal tissue and chronic renal failure. So this is the little graphic from the book that talks about how hypertension can lead to chronic renal failure. It's really important to control hypertension because it can be easily controlled with medication, and you can avoid chronic renal failure by doing that. So with nephrosclerosis, there can be a primary lesion developed in the kidney that might be secondary to essential hypertension. So it's usually treated with antihypertensive agents, diuretics, and beta blockers, and sodium intake is restricted. Excuse me. So there are a lot of congenital disorders possible with kidneys. Some of them we talked about in the congenital and genetic chapter. And there's just a list of them here. So this is another picture of polycystic kidney disease, which we know is an autosomal dominant. Wilms tumor is a kidney tumor that is the most common tumor found in children. It's a defect in a tumor suppressor gene on chromosome 11, and it can occur in conjunction with other congenital disorders. It's usually unilateral, and it's a large encapsulated mass. Sometimes, by the time it's diagnosed, there are pulmonary metastases.